Good morning, everyone. Thank you for joining us today for our discussion about STIs. We're going to cover a lot of material over the next hour and 15 minutes. Yes. Here's our disclaimer. Some of the terms we're going to use are modified to be consistent with the executive order. So we all know that STIs are not benign. We know that there's an increased risk of giving or getting HIV. There's long-term problems with pelvic pain, pelvic inflammatory disease, and there can be an impact on pregnancy, including infertility, premature or stillbirths. In addition, there are other conditions that can happen from untreated STIs, and we're going to cover that later this week with syphilis, for example, leading to permanent vision or hearing loss. So we need to understand about STIs and how do we relate to patients. You've had a discussion already about how do you talk to your patients. So we're going to use that algorithm about how to discuss with them STIs and also to discuss some of the specifics around the STIs that we normally see in clinic. So when we see somebody, for example, Jack, who's a 16-year-old, he comes into clinic and he, as a walk-in, he says he wants to get tested for STIs and he doesn't have any other specific complaints. You just learned about the 5 Ps from the CDC. So you ask him about partners. He's had 6 male partners in the past 2 months. He meets them on an app. He has 1 regular female partner as well. He practices oral, receptive, and giving sex, also vaginal and anal intercourse, both receptive and insertive. He sometimes uses condoms, but he doesn't like the sensation, and he has had chlamydia in the past. He doesn't want kids right now, but he doesn't actually know what his female partner wants to do either. So in general, with this type of situation, we would recommend some general screening recommendations. Here you see on the left-hand side of this table are the populations that we are concerned with, and they're men who have sex with men, patients on PrEP, patients with HIV. These may be what would be considered a higher risk population in terms of their sexual behaviors, their past STIs. Maybe some of them may have other risk factors, including local epidemiology, where the STI rates are higher in that setting. They may have been incarcerated in the past, which is considered an increased risk for STIs. You're going to screen all those patient populations at least annually, and it's recommended to test at each site of exposure. So as our patient revealed, he's exposed at the 3 sites: urine, rectal, and pharyngeal. So you would test all those sites at least annually. In these patient populations, you might consider testing at least every 3 to 6 months, especially if they're at increased risk. And this is what we do in our HIV clinic, for example. In non-pregnant women, you want to test at least annually for those under 25. For those over 25, you're going to test those who are at increased risk. And those are the populations I just mentioned. So past STIs, new partners, for example, a non-monogamous relationship, or if somebody's been incarcerated in the past, or somebody who lives in a geographic area where the rates of STIs are higher. You're going to also discuss the 3-site testing with women. And, this is different, and we're going to go over that in the next couple of slides. But based on, with shared decision making, you could consider rectal testing in women as well. We know that the vagina and the rectum are close together, and so infections can spread from one location to the other. Men who have sex with women, you're going to screen these young men in high prevalence settings. So it doesn't necessarily give us in the guidelines screening recommendations for men who have sex with women. But in cases where there's high prevalence of STIs, you're going to screen those men as well. Pregnant women are a special category. You need to screen them for STIs when they first present to care, in the 3rd trimester, and then at delivery, especially for diseases which can have significant consequences, like syphilis, for example, at the time of delivery and the 3rd trimester. Each state has their own laws about testing and screening for women, and you must be aware of those laws wherever you live. So why is this emphasis on extragenital testing? That means testing not just the urine in the genital area, but also the rectum and the pharynx. A lot of it's based on studies that we've seen in the literature. This study, published in 2019, looked at close to 10,000 patients who presented to a Department of Health in Kansas City. In this study, they looked at men and women about their STIs, gonorrhea and chlamydia, for example, and they reported that they missed many cases if they didn't test extragenitally, and it would change the management. So let's look at that in more depth. So here you see in these two figures, on the left hand block A and C are the cases of gonorrhea, and on the right-hand side is chlamydia. On the top of these figures is the pharyngeal testing, and the bottom is rectal. In the dark color are the patients who had infection only at the extragenital site, versus the gray color are those who had infection at both extragenital and the urinary site. You can see from these figures that are now put in the red that men who had sex with men, the dark color means without doing extragenital testing, many infections would be missed, and especially for the rectal gonorrhea. You can see up to 70% of those cases would have been, or total cases would have been missed. On the right-hand side, the same goes for chlamydia, especially in the rectal testing. This also holds true for women. You can see now in the red box, women who have sex with men. The dark color represents those cases that would have been missed both for pharyngeal and rectal infection if you had not done extragenital testing. So what did we learn from this study? We learned that most cases of gonorrhea and chlamydia in men who have sex with men would have been missed had extragenital testing not been performed. And a third of the cases of extragenital gonorrhea and chlamydia in men who had sex with men and women who had sex with men would have been missed had only the urinary testing been performed. This is significant. And so this should change your workup and your discussion about testing. So let's go back to Jack for a second. He did say that he had sex at all different locations, but now as you're going through your case with him, he says, well, I may have a little discharge. It's kind of mild. And you decide, well, I'm going to do a workup on him. As he's male, you can do a gram stain on that discharge that's there. But in our clinic, we have a standard workup. It's the 3-site testing. We would do a gram stain if we had that availability as well. We would do an RPR and also HIV testing and HIV prevention services. It's pretty minimal workup, but it should be just standardized in your practice, as Dr. Kohol just mentioned in a previous talk. So let's look at gonorrhea. I mean, when somebody says they have discharge, you can't distinguish between chlamydia and gonorrhea, but one of the more prevalent infections is gonorrhea. And you can see here on the left-hand side, this is a classic gram stain for gonorrhea, in which you have the gram-negative intracellular diplococci. On the right-hand side of this figure, this is data published from the CDC in 2023, and you can see that middle age group between 20 to 29 are the highest risk for gonorrhea in the US. And in fact, you can see on the left-hand side, the male rate, especially between 20 to 24, was the highest rate with 691 per 100,000 patients who presented with gonorrhea, compared to the women, which was around 610, especially in that age range. Some of this data may be off because of COVID, but it still represents a significant number of cases of gonorrhea. When we look at gonorrhea across the US, it's not just in New York where we have very high rates. And you can see here on the very left-hand side, men who have sex with men have the highest percentage of gonorrhea cases in this STI surveillance network. But across the US, the rates are relatively high with across the US, with various places, of course, with MSM being higher rates of infection pretty much universally across the US. But you can see here also in cases of, for example, Indiana, where women, so that's the green bar, represent the highest rate of gonorrhea in that state. So it does vary by population and where you're located. So what's the best treatment for gonorrhea for this patient, for example? Is it ceftriaxone 250 milligrams once? Is it 500 milligrams of ceftriaxone? 250 milligrams IM with the Zithro, 1 gram by mouth, or 500 with Doxy, 100 milligrams twice a day for 7 days? And Jessica, do we have a poll or? Responses are coming in. Okay. Okay. So remember, he came in, he had some discharge, we have a gram stain. What would you do? Aha. So 50% say they're going to give him ceftriaxone 500. Excellent. So this is using your data that you already have. You have a gram stain that looks like ceftriaxone, but 34% said they would give both ceftriaxone and doxycycline. And you wouldn't be wrong because you don't know. There's about 30% chance of being co-infected. And you want to be sure, maybe you're not sure he's going to come back for follow-up. So you could do both at the same time. Excellent. So the treatment recommendation, am I allowed to go on? I just need to go back on. Me? Here? Sorry. So the gonorrhea treatment recommendations in 2021 changed. So it's now 500 milligrams for treatment of gonorrhea, and it's weight-based dosing. So if somebody weighs less than 150 kilos, you can use the 500 milligrams. If chlamydia has not been excluded, and you guys were correct, it hadn't been excluded, you could give also the doxycycline 100 milligrams twice a day for 7 days. It's no longer recommended that you do dual therapy with azithromycin, and we'll go over why that is in a second. So you guys did really well. About 50% of us, actually, if we add both together, 80% of the people said that they would do the 500 milligrams with or plus or minus the doxycycline. So you're right in line with this SUNS report that looked at the estimated proportion of cases who were treated appropriately for gonorrhea. And the overall rate was about 77%. There are a couple sites where it isn't as high as we would like. We would, of course, like it to be close to 100%. But this is why we're doing this training and education and why we want you to share that with your colleagues. Sometimes you have to look at your electronic medical records. Sometimes it's that you haven't updated it to have the appropriate dose of ceftriaxone in your standard of care there. So please look at that when you go back to your clinical practice. Alternative treatment for gonorrhea for uncomplicated cases, if ceftriaxone is not available, could be oral cefixime. And please note here that the dose has increased. It was 400 before and it's 800 now. And again, with the caveat that if you haven't excluded chlamydia, you can also do the standard treatment for chlamydia, which is doxycycline. If somebody has a cephalosporin allergy, which if they have a pen allergy, it doesn't mean they actually have a cephalosporin allergy, so you can still use the ceftriaxone. But a true cephalosporin allergy, you would give gentamicin 240 milligrams IM, and you would give 2 grams of azithromycin with that as a single dose. Please warn them that they might have a little bit of gastric distress with that dose of the azithromycin. Unfortunately, this oral regimens are not reliable and they're not an alternative for pharyngeal gonorrhea. And we know this because the level of antibiotic in the pharynx is not enough to clear the infection in the throat with gonorrhea. So why were these changes made to the gonorrhea? Well, there are two basic principles, one being antimicrobial stewardship and the other being pharmacokinetics and pharmacodynamics. And let's review that now. So, in terms of antimicrobial stewardship, we know that the gonorrhea has shown an increase of resistance to antibiotics over time. This figure on the right, with the lines representing the resistant to antibiotics, you can see here the fluoroquinolones. Here is ciprofloxacin at 35%, and this is in 2019. And the other antibiotics as well, with azithromycin getting up to 4%. And in fact, we know overall the susceptibility to antibiotics for gonorrhea has decreased from 76% susceptible in 2009 to 45% susceptible in 2019. So there's a high level of resistance to gonorrhea now to all antibiotic categories. Unfortunately, this drive of antibiotic resistance has sort of leached over into other infections, including Salmonella, Shigella, and Campylobacter. And the CDC has published reports showing that this high alert level for resistant organisms because of the use of antibiotics in general. Likewise, the use of macrolide antibiotics in general has led to overall resistance among other organisms, as was shown in a study that was published in sub-Saharan Africa, where they gave azithromycin to the population to decrease infections, and then it led to, you can see the all the black dots to the right, increased resistance to other antibiotics, cross resistance over time. Likewise, when we look at pharmacokinetics and pharmacodynamics, we know that to kill gonorrhea, the ceftriaxone has to be above the minimum inhibitory concentration for about 24 hours. With increasing minimum inhibitory concentrations for gonorrhea, we know that we have to increase the dose. We also know that ceftriaxone does not get into the pharynx well. And we know that if we're not screening the pharynx, the patient might be infected in the pharynx. And if we give an oral antibiotic, we're not going to clear the infection at that site. So all these factors lead us to using a higher dose and trying to use the ceftriaxone. So when should we follow up this patient for retesting? Some basics of how you're going to set things up in your clinic. Would it be, I'm going to bring them back in a week, I'll bring them back in 4 weeks, 8 weeks, 12 weeks, or 24 weeks? And our poll is launched. Best guess. And it does depend on where we found the infection. So folks say 4 weeks to pretty split, 50, oh, close to 50% say 12 weeks, and close to 30% say 4 weeks, and 10% say 1 to 2 weeks. So you guys are sort of all correct. If it's just urinary infection, it would be the 12 weeks. But for pharyngeal infection, we want to bring them back in a week to 2 weeks. So here are some general principles for gonorrhea follow-up that you can sort of launch in your clinic and have it as standard of care. You want to tell your patient after you treat them to abstain from sex for 7 days. You want to reassess them for symptoms in 3 to 5 days. Maybe an epic chat message or some other way, texting with them, how you doing? And if the infection is in the pharynx, you're going to bring them back in a week to 2. For pregnant women, you're going to bring them back in 4 weeks because we want to make sure that this infection is cleared and we don't want any congenital infections with gonorrhea. In general, rescreening for example, urinary or rectal infection, we're going to bring them back in 3 months or 12 weeks, and it's a test for reinfection. So why is there a difference between retesting for the pharynx and retesting at other sites, or test of cure for the pharynx rather, and retest for infection at other sites? This is because infection in the pharynx is difficult to treat, but we also know that infection can persist in various sites. So what is the best time frame for doing that retesting? So there are several studies that were done, and their data is presented here in these two tables. We know, first of all, that reinfection usually occurs because of re-exposure. So that's the first thing you want to ask is, did your partner or partners get treated, or the people you're having sex with get treated? If the answer is no, then of course you're going to follow up with retesting. So when would you do it? You can see here with the nucleic acid amplified test, either RNA or DNA, by the time we get to after 15 days or after 14 days, by the RNA test, we're down to one patient or 1% chance of persistent infection versus 8 in the DNA. So after 2 weeks, you can pretty much be assured that if you test positive, it's not going to be a false positive due to persistent infection. And this is how the CDC came up with that recommendation to test at 1 week to 2 weeks for the pharynx for test of cure. As I mentioned, sometimes when the patients come back, their test of cure is positive. So the first thing we are considering is reinfection. But we don't know for sure, and because we're worried about resistance, we would say if somebody comes back and the test of cure is positive, you might consider doing a nucleic acid amplified test and a culture at the same time. This is because with the culture, you can detect for susceptibility, and we are concerned about resistant gonorrhea, as I mentioned before, and there have been cases in the US, especially in Massachusetts, we saw those cases where there was resistant gonorrhea. In those cases, you can either retreat with ceftriaxone, same dose or a higher dose, or you can go for the alternative therapy. Let's move on to another infection. So Jill is an 18-year-old. She's a female. She lives in New York City. She has sex with several male partners, and she once had chlamydia in the past. You go through the 5 Ps with her. So in terms of partners, she's had 6 male partners in the past 2 months, 1 female. She practices oral, vaginal, and anal intercourse a few times. She sometimes uses condoms, but never for oral sex. She's had chlamydia twice in the past. She doesn't want children right now, but and she uses oral contraception. So the workup is the standard workup that we had mentioned before: HIV testing, Hep C, 3-site testing. She reported testing at all those sites with shared decision making. You've elected to test all 3 sites. You can also test for trichomonas, syphilis, and pregnancy. And in all these cases, we would love for everyone to offer HIV biomedical prevention, either PEP or PrEP, depending on the situation. So there are many causes of urethritis, and we reviewed gonorrhea, but the non-gonococcal urethritis you can see on this list to the right include many organisms, and in fact, in up to 50% of the cases, we don't actually identify an organism. Chlamydia is one of the more common, and as we saw, or we will see in a second, that is the most common in the young adult population. MGen, which we're going to discuss at another session, is also quite prevalent. And as we test for it more, it's coming up more times. In men who have sex with men, Neisseria meningitidis has also been identified in that population. So let's look at the data from the CDC about the rates of chlamydia. And you can see here that if you remember the numbers for gonorrhea, this is significantly higher. So 3,435 per 100,000 compared to 600 for gonorrhea. So much higher rates for chlamydia in that 15 to 30-year-old age group. And you can see this is even more skewed. Twice as many women are infected with chlamydia in that age group than men. So STI testing for women was significantly changed in the 2021 guidelines, and they took into account what we had mentioned in the previous lecture and now sexual history taking and shared decision making. Based on a review, a meta-analysis published by Dr. Chan, they looked at, in 2016, they looked at over 33 studies that included women, and they were considering extragenital testing for gonorrhea, chlamydia in the rectum, and gonorrhea in the pharynx. What they showed in this review of these studies was that rectal gonorrhea was identified in up to 35% of the cases, and rectal chlamydia up to 77% of the cases. So what they concluded from this was that extragenital screening can increase the detection of gonorrhea and chlamydia in women, up to 50% compared to just doing urine alone. So this has a huge impact on sexual health for women and also for transmission of infection between partners. And this is why extragenital testing was added to the guidelines in 2021 with shared decision making for women. So in terms of treatment for chlamydia, the current preferred method is doxycycline, 100 milligrams twice a day for 7 days, with an alternative now being what we used to use, 1 gram of azithromycin once. And of course, this is the preferred treatment for pregnant women because of the toxicity for pregnant women with the doxycycline. So why was this change made? Well, for chlamydia, it was due to microbiologic failure rates, especially among men who have sex with men, and especially among rectal infections. So let's look at that a little bit closer. In this study, so this was a randomized trial looking at oral azithromycin versus doxycycline for urogenital chlamydia among adolescents in correctional facilities to evaluate the non-inferiority of azithromycin versus doxycycline. The primary endpoint was a 28 days treatment failure. In this closed population, so it was in correctional facility, they were watching, there was directly observed treatment. The efficacy of azithromycin was 97% and doxycycline was 100%. So azithromycin was non-inferior, but as you can see here, that doxycycline was actually better. But what about rectal infection? So some recent studies looked at 7-day course of doxycycline compared to azithromycin. And in these studies, so these were done both in the US and in Australia, looking at a 7-day course of doxycycline, they found that doxycycline was significantly more effective compared to azithromycin by 20 to 26%. So said in a different way, it could be 1 out of 4 patients with rectal chlamydia may fail treatment if you use azithromycin. And since we don't test women necessarily for rectal infection, we might be missing those cases, and those cases may be treated with an inferior drug like azithromycin compared to doxycycline. So this is why the guidelines changed. So we understand that, sometimes it's difficult to give the doxycycline or azithromycin. And really, you have to think about how do you implement this in your clinical practice. You have to weigh the ease of giving azithromycin with the efficacy of doxycycline. You have to also understand access. So we know in several studies that adolescents who are given a prescription in the emergency room, only close to 60% of them will fill that prescription. So that's then going to lead to a lot of treatment failures. We do know if you're worried about adherence to doxycycline, we know that studies show that people can be adherent, that 60 to 90% of the patients will take the 7-day course. As mentioned in the previous lecture, especially in the young adult population, we're worried about confidentiality. So there may be reasons why you need to give the azithromycin. The patient might not have a place the doxycycline, doesn't want their parents or their partners to know. And you might be worried about the side effect profile. In addition, there might be reasons why you would choose azithromycin. So if somebody was pregnant, if somebody had an allergy to azithromycin, if you're worried about adherence, and if they're unlikely to be able to obtain a doxycycline, and you can give azithromycin at the point of care. So you have to weigh the ease of giving the one drug, the azithromycin, with the efficacy, and weigh what you're going to do in your clinical practice. This is our algorithm that you could adopt for your practice as well. In this case, if you have a suspected patient with chlamydia, the most important thing is to decide if somebody might have a rectal infection. You're going to want to go with a doxycycline because it's more efficacious and significantly more efficacious. But if somebody's pregnant, you're going to go with azithromycin. And in general, it's going to be shared decision making, knowing that the preferred drug would be doxycycline. Again, with chlamydia, how do you manage these patients in follow-up? You're going to generally ask people to abstain from sex for 7 days, make sure their partners are evaluated and treated. You're going to repeat testing in 4 weeks for rectal chlamydia if you're using the non-preferred regimen. So if you're using azithromycin, because I showed you there are failures with azithromycin. In addition, if someone's pregnant, you're going to retest them because we don't want congenital infection. And then in general, we're going to rescreen for reinfection at 3 months. Very similar to gonorrhea. So what did we do with Jill? We gave her the doxycycline. We did all this testing. We offered her prevention services. Let's move on to another infection. And we're going to have Sally this time, and she has a discharge. So this is a text that you might get from either your children or their friends. Hey, Sally, how's it going? Well, can you ask your mom a question? I had some vaginal discharge in the past week. Oh, bummer. Same as before. Yep, I don't think I have an STD, but so maybe anybody who has college-age students, you might get these texts. So let's talk about that. How do you approach that? So vaginitis in general can present as discharge. It can present as itching, burning, or irritation. There are multiple risk factors for this. So you can have multiple partners, female partners, sometimes even the copper IUD. So one of the main infections is bacterial vaginosis, and especially in this age population. So recently, BV was considered an STI, or could be considered an STI, because of a new study that showed that treatment of partners led to less recurrences. In general, bacterial vaginosis is really dysbiosis. So what does that mean? It means that your normal bacterial flora, so your lactobacillus and other anaerobic flora has been, taken over. It's been a dysregulation of the amount of pathogens that are there. And really you have to think of the patient population if you're going to decide about screening. We don't screen for BV. We test if somebody is symptomatic. And we really do not screen asymptomatic pregnant women because we know that there's no risk to the fetus in pregnancy. So how do you diagnose bacterial vaginosis? There are diagnostic scores, and then there's diagnostic testing. So if you have access to a microscope, or you can send a slide to your lab, you can use either the Nugent score or Amsel's criteria. So the Nugent score looks at a gram stain of the vaginal flora. So Vaginal flora is normal to have bacteria there. You can have up to, the way that they score it, 3, it's a category 3 of organisms. If you have more than 4, it's consistent with Gardnerella, and more than 6, it's consistent with BV by the Nugent score. The Amsel's criteria takes in signs and symptoms as well. So you need to have 3 out of the 4 of the following criteria: a milky discharge, clue cells. So those are those cells where you have the little stippling on top of it when you look under the microscope. You need to have a vaginal fluid pH that's greater than 4.5, a fishy odor, or you can use KOH to detect and do the whiff test in order to detect that fishy, to bring out that fishy odor if you have that also in your practice. There are some near or point of care testing that's also available that are quite good. And we'll go over that in 1 second. And then nucleic acid amplified test has also entered into the BV realm, like it did for gonorrhea and chlamydia. And these have pretty high sensitivity and specificity and are available and are FDA approved as well. So, what are some of the risks and sequelae of having BV? Well, the problem is that it's often recurrent. So, up to 30% of women may have a BV that recurs. It can complicate GYN surgeries, for example, as well. So, you would want to diagnose it and treat it before somebody's undergoing a surgical procedure. There's data that it may increase the risk of other STIs, for example, MGen, and it may be associated with an increase in HIV susceptibility. There are some prevention strategies and protection that have been reported in the literature. Male circumcision, for example, using condoms, not having sex, and hormonal contraception may be protective. And there is some data about probiotics may be used for also decreasing bacterial vaginosis. The treatment has not really changed in the 2021 guidelines. The standard recommendation is metronidazole given at a 500 milligram dose twice a day for 7 days. You can also use gels, however, either metronidazole or clindamycin gels over 5 to 7 days, for example. There are alternative regimens if somebody cannot take metronidazole. You can use clindamycin. Secnidazole is also available, or tinidazole, but these are often more expensive. But the advantages of those, for example, secnidazole, is that it's a single dose. It does only have a 93% cure rate, however. There are some new creams that are available over the market that are also pretty good, but again, you see by the rates of cure from all of these that they're not a perfect treatment of choice. There is no perfect treatment of choice. So BV, this is the study that sort of changed BV from being just a pathogen to being considered a sexually transmitted disease. So this was published in the New England Journal in 2025. It was a study that was done in college students, and they looked at the treatment response in those patients. They evaluated wet mounts. They did some also point of care testing, or NAT. They screened symptomatic women in this study, and they treated them either with metronidazole or the various gels for 7 days. In this study, they found that those patients whose partners were treated both with metronidazole and a cream on the penis, that they led to fewer recurrent cases at a 12-week period of time. And in fact, the trial was stopped because that group had a better response. And you can see this on this Kaplan-Meier curve on the left-hand side. So what about other vaginal discharge diseases? And this is a common complaint, especially in those college campuses. So trichomonas is something that should be considered. This is important because there are implications, especially for pregnant women. We know from various studies that it can lead to untreated trichomonas in pregnancy, can lead to premature rupture of membranes, premature birth, and in other cases, HIV acquisition or endometritis. Testing, this asymptomatic screening is not usually recommended. It is only recommended in certain populations, like, for example, in correctional facility, patients who are in correctional facilities. Patients who are symptomatic, however, you can test both males and females, especially if they're presenting with a discharge for women or on a speculum exam, a strawberry cervix. For males, if they're having urethritis or persistent symptoms, for example. Retesting for persistent infection should be done. And even if you can't clear them, there is resistance testing, but it's not routinely available. It was offered previously by the CDC, and I'm not sure if that lab has reopened yet, but they have been helpful in the past for cases where there's been resistance in the trichomonas. These are the diagnostic tests that are available. Again, you can see the variability, for example, in the wet mount that could be done. Nucleic acid amplified testing has really become the standard of care for almost all STIs with high specificity and sensitivity. Point of care testing is also available, depends what is allowable and available in your clinic, and the sensitivity is okay, ranging from 67 to 100% in various cases. The treatment for trick has changed. It's recommended for women to have a 7-day course of metronidazole, 500 milligrams twice a day for 7 days. There have been no published clinical trials on treatment for men, so the male treatment dose has remained at the 2 grams once. The alternative now for both men and women has been recommended, the tinidazole at 2 grams. For persistence, the treatment has been, it's been recommended that you increase the dose, for example, of metronidazole or use tinidazole at 7 days. You can also do combination therapy where you're doing both oral and vaginal dosing of antimicrobial agents. So here is the study. This is the rationale about why the dosing was changed. This was a multi-center study that was published in 2018. They looked at over 600 women who were randomized to get 2 grams of metronidazole versus 500 milligrams. The primary outcome was a test of cure at 4 weeks after completion of the treatment. The patients in the 7-dose group were less likely to have a positive test of cure at that 4-week mark compared to those who got a single dose in which it was 11 versus 19% of the cases. So the relative risk was was improved for the twice a day 7-day dosing with a p-value of less than 0.001. Let's move on now to vulvovaginal candidiasis. So again, this is really, patients will present with nonspecific symptoms like dysuria, pruritus, dyspareunia, or vaginal discharge. 75% of women may have at least one episode of this over the course of their lifetime. Vulvovaginal candidiasis can be considered uncomplicated or complicated, and let's look at how to distinguish between the two. Uncomplicated really happens sporadically, it's infrequent, it can be mild, for example, and it's more likely to be caused by Candida albicans. Complicated vulvovaginal candidiasis happens when somebody has more than 3 cases a year. It can be very, very severe. Oftentimes, we'll see non-Candida albicans strains as well occur in complicated disease. It's more common in women who are immunocompromised or folks who have diabetes, for example, or those who are on steroids. So how do you test for vulval candidiasis? Again, if you have the ability, you can do a wet prep or use saline. KOH will, you can see a budding yeast particles under the microscope. You can also send a culture, and really culture and susceptibility testing is really important if somebody has a severe disease because it could pick up those non-albicans strains or those cases in which you have the azole or fluconazole resistance is detected. There are some PCR testing for yeast, but it's really has not been FDA cleared yet. Recurrent vulvocandidiasis is really important to do that culture, as I mentioned, because it also impacts the treatment, because you're going to want to use oral therapy in those cases, and you may extend the therapy up to 6 weeks, for example. So what does the treatment for uncomplicated infection look like? So over-the-counter medications are available, both clotrimazole or miconazole, whatever you will be covered by the insurance, and you should look at that and see what is covered. You do have to warn the patients that some of these medications may be oil-based and they may weaken condoms, so they need to be aware of that. Some cases you can use a single treatment dose, or in other cases, 3 to 7 days can be prescribed. Likewise, you can also give fluconazole as a single dose. Oftentimes people want to just take that one treatment, one and done. And so keep that in your pocket. There's no reason to not do that for patients if that is what they would prefer. So for complicated cases, you're really going to use an oral or a topical therapy, and you're going to extend it. You're not going to do that single dose treatment. You're going to do 7 to 14 days, or in some cases, you can try every third day for 3 doses. For recurrent vulval vaginitis, and remember that's if they've had over 3 episodes in a year, you're going to want to use fluconazole, and you could do weekly dosing up to 5 months because it can recur or can be long lasting. You can also do extended courses of this. I want to remind everyone here, especially in for providers who are treating pregnant women, that fluconazole use in pregnancy is not recommended because there's an increased risk of congenital anomalies and spontaneous abortion. The study that's highlighted on the right that was published in 2016 looked at the patient population in Denmark in which there were over 1 million pregnancies and fluconazole exposures. They randomized people to 1 to 4 in terms of fluconazole to unexposed, and they showed there was an increased risk of spontaneous abortion in the fluconazole group with a risk ratio of 1.48. So really, it's advised to not use fluconazole, especially in pregnancy. So what about the non-albicans candidiasis? And it's not common, but we do get a lot of questions about this, so I wanted to mention it briefly. 10% of symptomatic vulval candidiasis can be caused by non-albicans strains. These are the strains that are listed here. So more commonly, parapsilosis, glabrata, for example. And there are some other less common strains. The treatment is usually longer, and oftentimes these cases will have resistance to the azoles. I'm not saying don't try fluconazole. You can try it, but if you're worried about resistance, you should do a culture and ask specifically for susceptibility testing. In most cases, the lab will not routinely do susceptibility because it's not a sterile site, and so you have to specifically ask them for that. The first line of treatment for these non-albicans strains can be placing intravaginal nystatin, for example, or boric acid, which you can get suppositories made with that, with 600 milligrams daily. And you see the length of treatment is quite extensive, 14 to 21 days. There are other medications that can also be made into suppositories. So for example, amphotericin B or flucytosine cream. You can also use combination therapy with ampho and flucytosine. And there are even studies which have shown the use of voriconazole or itraconazole. But these medications also have side effects and toxicities that you have to evaluate before prescribing them for your patient population, especially in the immune compromised population. So let's move on to, I think it's our last syndrome. BB has pain. So she presents with dysuria and abdominal pain for about 2 months after having a chlamydia infection. Her exam shows she has cervical motion tenderness, and you feel like this is consistent with mild PID. You can see here on the right a figure of the uterus with the fallopian tubes and the ovaries. And here you can see here represented PID, an infection or an abscess in one of the fallopian tubes. So sometimes cervicitis can go on, especially if untreated, and sometimes if treated, to cause PID. It can be mild or it can be moderate. There really isn't any new information about how to define PID. It's really a clinical diagnosis. So does somebody have fever, abnormal discharge, white cells in microscopy? Again, that wet prep. If you're going to be able to do laboratory testing, do they have elevated inflammatory markers? And do they have a test positive for gonorrhea and chlamydia? You don't have to have a positive test. You only need to have 3 of these criteria to minimally meet the diagnosis of PID. The treatment for PID, there's a new regimen that's recommended. You can see here is metronidazole has been added to the regimen. You are going to give, oftentimes we can do standard treatment for gonorrhea and chlamydia, so ceftriaxone and doxycycline. Again, see here that the dose of doxycycline is 14 days, not 7 days, so extending the course. And metronidazole is used for those anaerobic organisms or also to cover other organisms, for example, and it's for 14 days. So why was this done? So this was done based on a study that was a double-blind, placebo-controlled study over 200 patients. They looked at treating with metronidazole or placebo, and they looked at symptoms at 3 days and the presence of anaerobic organisms in the endometrium. They found that at 30 days after the treatment with or without metronidazole, that the patients had less tenderness, which was statistically significant, fewer anaerobic organisms, which is no wonder because they gave metronidazole, but also a decrease in mycoplasma genitalium, which was a little, we don't really understand why that is, but they did show it. And with a similar adverse event profile in both arms. So, in summary, for vaginitis, what's new for vaginitis and PID? So, vaginitis, there are some single dose regimens for non pregnant women, like secnidazole or the Metrogels. There's no data linking metronidazole, and we didn't really talk about this, but with alcohol, so you don't have to warn people anymore. I mean, in general, it's not good if you're drinking if you're pregnant, but in terms of non-pregnant women and drinking, that recommendation no longer exists. For trichomonas, there is a test out option for women in correctional facilities. That's the only screening recommendation. And the treatment has been not a single dose regimen, but 7 days is recommended. And only for males can you give the single dose regimen. For Candida, there are some PCR detection methods, but they're not yet FDA cleared. There is data for fluconazole causing spontaneous abortion in pregnancy, so please avoid this if somebody is pregnant and has candidiasis. For PID, there is no new change in how do you diagnose it, but there is the recommendation for giving metronidazole, for example, when treating PID for at least 14 days. So this is a little advertisement for our Prevention and Training Center. We are the CDC-funded New York City STD Prevention and Training Center at Columbia University. And we offer all these resources for your training and education. I believe that's it. That's the end of the slides.
All right, fantastic, Dr. New. Thank you so much for that presentation. If you have any questions for Dr. New, please put those in the Q&A box, which is located at the bottom of your Zoom screen. All right, we have a question here about pharyngeal gonorrhea. For patients with significant barriers to transportation, how important is the repeat testing for pharyngeal gonorrhea in 1 to 2 weeks? We frequently have providers testing at the 4-month follow-up because of those barriers.
You know, that's a great point. You have to work within your patient population's ability to access healthcare. It's, really, again, shared decision making. If you're able to give them the ceftriaxone, I have less concern about the cure rate with that. If you're giving an alternative medication, I would be concerned and make sure that you bring them back. There are some home kits now that are FDA approved that the patients could order, you could send to them, and they can do home testing, and then send that in. Again, that's another cost, and that might also be a barrier, but that's another way of being able to do the 2-week testing if there is concern either about reinfection or lack of efficacy of the treatment that you gave.
Great, thank you. Regarding pregnancy and bacterial vaginosis, I thought there was an increased risk of preterm birth with BV. Could you speak to that?
I think the data is mixed for BV and preterm birth. We know there's definitely linkage with trichomonas, but the data has been mixed with the BV. And that's why there is no recommendation for screening asymptomatic women with BV for BV during pregnancy.
Got it. Thank you. Another BV question. Do you provide expedited therapy for male partners of patients with BV?
So COVID had some good things happen during it. It was, allowing us to do more medical interventions either by telehealth or just empirically. In that time frame too, many states expanded expedited partner therapy to include treatment. Oh wait, so the question was BV? Yeah. So given the study that showed treatment for male partners and given the expansion of the expedited partner therapy recommendations, you can now, although I think the expanded recommendations were more for trick, we might extrapolate also to BV in that situation. But remember, it's both oral dosing and the creams for the male partner for treatment. At least that's what the study used.
Thank you. Would you mind clarifying? Trichomonas in women is treated with metronidazole 500 mg POQD or POBID for 7 days?
BID.
Okay.
I think so. Yeah. Was something wrong in the... Oh, I see what you're saying. That we have a typo in that slide. Thank you.
Okay.
This is the treatment recommendation.
Great. Thank you. All right. Can you discuss any CDC or ACOG recommendations for treat? This is another BV question for treatment of particularly male and also asymptomatic female partners for females with BV or recurrent BV.
Can you repeat that?
Yes. So the question is asking about existing recommendations, either from CDC or ACOG or others, for treatment of partners of women with BV or recurrent BV, whether those partners are male or female and asymptomatic.
So the guidelines were changed in 2021, and because it's not a living document, the latest literature, for example, that study that I just showed you, it hasn't yet made it into the CDC treatment recommendations. I think moving forward, the hope is that the CDC will, STI guidelines will become a living document, meaning that it'll be changed in real time as new data comes out. So it hasn't quite made it into the CDC, but based on the current literature, and I don't know, since I'm not an OB, I don't know if ACOG has changed their recommendations yet either based on that study, but the study was just published in 2025. So and guidelines don't change that fast. So I have a feeling that hasn't made it to those locations yet. But that study was published in the New England Journal and it made quite the splash. So for treatment of partners with BV. Here's a citation if you want to look it up, and then could bring it to your clinical practice manager to show them that this is why you need to have that partner therapy be available for BV.
Great, thank you. One other question here. I'm under the impression that penile swabs are more sensitive than urine. If yes, is there a reason why we often use urine gnats for GC and chlamydia screening in males? I assume increased screening rates due to comfort of the exam versus urine samples.
So for males, that is correct. I think there is not a difference there's no improvement in doing the swab for gonorrhea and chlamydia in males compared to the urine. And remember, it has to be the first catch. So you have to tell your patients, don't wipe everything off, just the first urine, that is what you want to collect. And because there was no difference between the swab and the urine, they left that as urine recommended for males. If you need to do resistance testing, however, you need to do a swab. For women, you're correct. There are some studies that show statistically there is a slight improvement in the detection of gonorrhea and chlamydia with vaginal swabs compared to urine. But the ease of doing the urine and having patients self-collected, either vaginal or urine swabs, or being able to do these studies in non-medical locations has led us to doing more urine-based testing in women than vaginal swabs. But you are correct, vaginal swabs is slightly better in terms of detection of gonorrhea and chlamydia.
Great. Thank you so much. All right. So if there's no further questions, which looks like right now we don't have any, so we're going to go ahead and pause there. We're running a little bit ahead of schedule, so we are going to take a break at this point until 11:15. So I just want to thank Dr. New so much for this presentation. So everyone will be taking a break. If you have other questions that come up, feel free to keep putting them in the Q&A. We'll be keeping track of them, and we can also respond to them tomorrow morning during our morning Q&A. But for now, stay tuned, take a break, do what you need to do. We'll gather back at 11:15 for our next presentation of the day on syphilis. Thank you, Dr. New.
Thank you, everyone.